This is going to be a super important case, as this is a man that is 39 years old, has been under my care for over a decade, and has a condition called hereditary hemochromatosis. And I only picked it up in the last year or so. Let me present this case to you guys, and this man is here today to help us with this. I can't tell you how important this is, because when you look just at red blood cells and a CBC and hemoglobins, hematocrits, you're going to miss it. I missed it. So this is a young man who initially had a congenital reason, we think, for having low testosterone in his late 20s. He's not a steroid user. And he came to me with low testosterone legitimately. We checked it several times. Physicians agreed. People saw it. He didn't feel well. And initially, I just thought back then that he had low T, because just there's young guys that are in their late 20s that he's a healthy man, didn't drink, didn't smoke, otherwise. And he just had his congenital testosterone endogenous system just petered out, and he had low T. Now we look back and see maybe he had something else going on with this. So let me just open up the case. Initially, when I took care of this man, as I do everyone, I was just looking at CBC for the red blood cells. And of course, his were slightly elevated. I have evidence back here in 2017. His hemoglobin was 17.3 grams per deciliter, hematocrit 50.6. Because he was normal, that's normal, he wasn't phlebotomizing. I wasn't checking any details on the iron studies, and you guys have to focus. You have to do this yourself now. You have to look at, and when we started to look at this, his first evaluation in October of 2021, his ferritin was 1,598 nanograms per milliliter. The range goes up to 380. So, and we had issues with his saturations, and his total iron was massively elevated. And at that point, I referred him to hematology in Hartford, Connecticut. Dr. Todd Election, with an A, is an apple, and you could look him up. He's a brilliant physician and a very decent man. Let's begin now with a quick background. So this is a young man on testosterone for years, did not have excessive polycythemia, otherwise felt well, had no contributing medical history, family history, right, sir? You have no family history for hereditary hemochromatosis, which is really interesting. And vital signs, how tall are you, sir? How much do you weigh?
5'11", and I'm 235 pounds.
Right, so he's been a little bigger, a little smaller in his life, but he's well built, he's very muscular, and he's just a very large man. So, and he doesn't drink, he doesn't smoke. We know the alcohol issues are very important with iron overload, so we can talk about all these things. But I want to get right into the case. When I initially saw the iron overload, I immediately referred you to hematology doctors. And at that point, please tell us from there to now exactly what they've done.
Sure. And I'll do that, but I'll back up for just 1 second. You know, several years ago for Christmas, the family got each other the DNA test kits. And so, you know, we kind of went around the room on Christmas Day, and we all spit in the vials, and then mailed those away. And you know, several weeks later, we were all excited to kind of go through the online app on our phones and share, you know, where the geographical regions that we're all from. And, you know, there's always surprises in there, and you can upgrade to the health portion as well. And, you know, there's all kinds of indicators in there. And a lot of them, I don't think people really understand even what they are. Most of them, if you're healthy, come in negative. But there was one that popped up, and it said an increased likelihood for hereditary hemochromatosis. And I did remember looking at that, and then seeing that there was 2 types of gene variants around hereditary hemochromatosis, and that I had actually shown in that test that I had both of the gene mutations. And, you know, I got to look back now and say, you know, it was kind of naive of me to just say, well, that's interesting, and move on. because again, I otherwise felt healthy. But it wasn't until you did your blood work with me to find that iron saturation level and those elevated ferritin levels that I made the connection back to that DNA test and said, wow, that is probably the first sign that I should have maybe even asked for proactively some of these tests. But luckily you did them and we discovered it from there.
And let me just say this though. So when I made the diagnosis, again, after years of looking at your CBC only, which to a regular good doctor that's managing men on testosterone, that's all they do, sir. So guys, you have to pay attention. You can't just accept that the CBC is normal because his CBC was essential normal and he wasn't phlebotomizing. So you need to get everyone, do you agree, sir? Everyone needs to get to look at the ferritin all day long, and iron studies. They may come together. The iron studies are total iron, the iron transferrin or saturation, it's called TIBC, and then it may not include the ferritin. It's going to be an egregious mistake if you don't add that ferritin. And that's how I picked it up. Subsequently, when I sent you to the hematology doctor, I wanted to have you all packaged up with a bow. So I did we ordered the hereditary hemochromatosis HFE gene analysis. Here it is. This is the real. This is not just the 23andMe spin on the thing. It says, and this is where when we saw it, we were like, wow, oh boy, let's go to hematology guy. Positive for 2 copies of the HFE gene pathogenic variant. C is in cat, 28, 2, Y is in yellow, times 2, homozygote. And of course, you guys, when you get this incredible information, it gives information that approximately 60 to 9% of individuals, biochemical diagnosis of hereditary hemochromatosis, have this gene type. So when I think in the world, sir, like I look at men and I say, you're the average bear, you're the common bear, you're the uncommon bear. Common things are common. Here it is. So Caucasian men from European ancestry, up to 10%, thanks to your doctor, I learned this stuff, up to 10% of us will have some variation of one of the gene. There's like 7 genes. You have gambled and you have 2. It's a spontaneous mutation because your mother and father don't have it. It's unusual. It's unusual. It's usually diagnosed on a family history. You hear, well, what is your father or your mother? And you hear, my uncle has it, and it runs through because it's both almost autosomal dominant and recessive. It's very complicated genetics. And you have doctors. That's why when you take the health history, guys, my anabolicdocapp.com is here for you. It's a virtual men's health clinic with me organizing it all for you. I'm obviously not your doctor, but you could learn all this stuff yourself. And that's why I love to do this for you. So, sir, so you have the diagnosis of the real homozygote, hereditary hemochromatosis. Guys, it's pretty damn rare. I have a couple of these guys, a handful out of thousands, maybe 6 right now. But when you see that ferritin that high, it's going to be deadly. You know that, sir. If you don't do anything about it, it's going to shorten the life. Let me just talk about real quick about what will happen with the outcomes, manifestations of undiagnosed and easily treated. We're going to talk about hereditary hemochromatosis, manifestations of diabetes, bronze diabetes. The skin color starts to change because of the deposition of the iron. Heart failure. This is the sad part. Heart failure, liver cirrhosis, and we're going to talk about, you had an MRI where you had the beginning of iron depositing into your liver already without having elevation of liver function, LFTs, without having any indication of it on chemical analysis on a basic metabolic or advanced lip panel, anything at all. You're a normal, healthy man, completely subclinical and completely silent. Joint issues, deposition, hypogonadism, as you and I have discussed, that you probably had hypogonadism because of the beginning. We don't know, your ferritin has probably been elevated for a decade or so. So, sir, that's again for the presentation for the group. That's this clinical presentation acutely of who you are, your manifestations, your presentation, and then some of the basis of what hereditary hemochromatosis is, and that if you're a man on androgens and you're one of the 10% that have partial genes, that's why we see those red blood cells that are tough to control, but you see ferritins that are normal and low. And you can't just be dumping blood because you're going to over dump. You don't need to dump. You have to understand the hematology on this. Sir, tell us about the progression of your case.
Absolutely. So yeah, the first thing to do, at least in my eyes, was to better understand what I was looking at. And you presented a lot of the, a lot of the breakdown of what's going to happen with iron overload. But I certainly wanted to educate myself. And then obviously when you connected me with the specialists, we went even deeper into that. But to in layman's terms, the fact that, your ferritin range should, the upper limits of the ferritin range should really be around 300. When you start to see numbers like 1700, it's a kick in the pants to figure out exactly what you're going to do from there. And so first things first, once we've determined that we had both genes, once we determined that our iron saturation levels were over 95% in the body, and that our ferritin levels were 1700, it was immediately the course of action was going to go to weekly phlebotomies. And I had come in with some of my own research saying, well, that seems aggressive. It seems even kind of prehistoric as far as treatments, just taking blood, right, leaching blood. What about these chelating drugs and things like that? But the more you learn, you realize that there really isn't a better therapy to rapidly bring down your ferritin levels and ultimately your iron percentage levels than by phlebotomizing. And so we set up a schedule weekly of 500 milliliter pulls. And so we're doing that every single week. And at first, the body really did resist. In fact, we did a total of 1,000 milliliters over 14 days, and I actually went up. The first thing was that I went up. And then once we've kind of regulated and continued to test ferritin levels, we've been doing this for several months now, where every single week we're pulling 500 milliliters. We started to see, precipitous drop, roughly 200 to 250 points every 4 weeks. We've even increased that now. I think some of the other things in research have helped, right? So making sure you're being super responsible with any alcohol that you intake, because we do know that taking in alcohol does spike ferritin levels. And, it was an eye-opener to me to think about ferritin as kind of a school bus. So it's a school bus that transports, the iron molecules to our red blood cells and throughout our body. And that, without those high ferritin levels, you don't have that vehicle to transport the iron and then ultimately deposit the iron and build the iron up in the organs of the body. So that helped me understand why it was so important to keep my ferritin dropping, and then ultimately, hopefully, keep it low. Because if we do that, then hopefully my body can actually start to break down some of the iron deposits that I've had probably for the last 20 years.
Tell us about the MRI of the liver.
Yeah, so knowing that with iron overload, the two places, number one is going to be your liver. Your liver is going to collect the majority of that iron. After that, probably the second most important is making sure that you're not getting iron overload in the heart. But we know it is going to collect in several different organs, including the brain, the pituitary, and even the testes in men. Those are all common locations for iron deposits to start to build up over time, and you start to see that around 35 to 40 years old. We did the MRI because we needed a baseline of just how much we have deposited in the body, and there is a scale for that, and it's a milligram scale on a dry liver that's tested through the MRI imaging. And you want to be at the 1 gram to 2 grams, is kind of normal at the age of 40 as a male to be healthy. And then you're going to have a 2 to 3 and a 3 to 4, the range just continuing and the scale going up from there. And I did come in at a 5.1 to a 7.2 milligrams in my dry liver. And that is the upper limit. After that, you really do have an increased level of all kinds of things, liver failure, strokes, cardiac disease, even diabetes in a lot of cases, more advanced cases of hemochromatosis. You would also probably start to see elevated deposits if that was the case, like I mentioned, in the pituitary and the testes. And so you would have most likely, so low libido, probably not be able to produce as much sperm. You're going to see even different hormones like testosterone dropping. So mood changes and things like that. So really, really important to get ahead of all this and
So
really
this is,
understand the impact.
so looking back, I mean, this is a rare cause of male hypogonadism. It's a
Yep.
rare cause, and again, the genetics are usually there. Like you see a mother and a father or uncles, kind of a bloodline where the patient will say, "I'm a primary care doctor. I've picked this up on a couple of regular guys, apart from my testosterone practice and working on men and androgens." The guy just says, my father and his brother, they have to give blood all the time. And I'm like, really? And then you look at the guy, this is a 28-year-old guy at the time, way back, and you look at his CBC, and he had an elevated hemoglobin and hematocrit, but he was not on testosterone. So when you look at men on testosterone, sir, everyone is going to be like, you're on testosterone, so it's elevated, right? So with you didn't really have it that elevated, but your ferritin was getting off the chart for maybe a decade or so.
Mm-hmm.
And it's an incredible case. Okay, so there's the pathology. The guys have to understand it. You're super bright on this. Wow, I'm amazed. You know a lot more than me about hereditary hemochromatosis, that's for sure. So you're working with this great doctor. Tell us, let's talk, you're on testosterone. No, let's talk about this. You have to, and your doctor told me, he said, Tom, Dr. O'Connor, he said, when you're dealing with the men that you're dealing with, not steroid users, these are men that are, if you're on testosterone and you're phlebotomizing, here's what's going on, guys. He said, you're on the gas and the brake at the same time. So if you stop testosterone, this clinical presentation probably would go away to a great extent. You wouldn't have to phlebotomize that much. You would get down very quickly, or you'd get down, but more quickly to that desired ferritin goal. Okay, but because we need to have you on some testosterone, and you're on 0.5 every 5 days, you're on a very small dose, what the average bear is on, and your levels are always good because I check your levels. You're not excessive, and that's for the sex drive and for the mentation. And there's millions of men like this. Forget the cause of low testosterone. They're on testosterone, and then you have to manage them. And this is the red blood cells and the iron information. So because you're on testosterone, however, not much, but injections are going to be more powerful than gels, but your brain likes the injection with the free testosterone. And that's how it works. So you're on the gas and the brake. You're finally removing. You've been phlebotomizing for how many weeks straight?
Well, I guess we started back in March, so you can do the math from there.
This is mid-June.
Right, exactly.
Unbelievable.
And so
You guys, this is a case you're not going to believe, and I have to present it. Okay, sir, your hemoglobins and hematocrits are perfect. They're not low. He goes for all the phlebotomizing, but his hemoglobin stays around 15, and your hematocrits are like 45%. But your ferritins are up, and they're breaking down. Let's wrap it up, sir. Give us any closing points that for men in the world on testosterone, what can you recommend for that?
Well, I got to tell you, just really the importance of this blood work, and really the importance of having someone like you, Doc, in your corner to, one, identify these things, but then to understand the best way forward. Honestly, if somebody didn't know as much about testosterone as yourself, right, the world's only testosteronologist, you may have a gut reaction to pull somebody off that testosterone and then just focus on the treatment of the hemochromatosis. And I got to tell you, this is just my uneducated opinion, but I'm living through it, that would have been really a terrible course of action. One, because you're going to have a patient that begins to suffer in so many ways. But two, it's important to note that if you are on testosterone and you are one of the rare people with hemochromatosis, there is a silver lining. I would not be able to keep up the frequency of my phlebotomies and keep my hematocrit and hemoglobin in a very safe range without the testosterone, because I'm reproducing red blood cells at a faster rate. So I'm able to treat this hereditary illness in a more aggressive manner without having to back off the frequency and the number of phlebotomies I do because of that testosterone support. I also am able to stay, happy and healthy from a mental perspective and a physical perspective because of the regimen of testosterone. So those two things really do harmonize and work together really, really well. The other thing I'd say is make sure you're talking to people like Dr. O'Connor, but also whoever is helping you with your hemochromatosis to make sure that they're not still doing the treatments of the past. And one of those gut reactions too would be your diet. Obviously, you're accumulating the iron from the food you eat. If you're a big fan of red meat like I am, that's actually going to be a huge producer of iron. But the gut reaction historically has been to pull out the red meat and to pull out the meats and the chicken and the eggs and all of those things. And now what you're doing is you're causing all kinds of other secondary health issues in somebody because they're not getting the right nutrition. They're not getting enough protein. If you're phlebotomizing and you're treating this properly, you got to stay on that diet. You got to stay strong. You got to stay healthy.
That is incredible, because even me, as I give recommendations to my patients all day long that don't have hereditary hemochromatosis, but they're sensitive to androgens because they have one of the genes or a permutation and combination of some of the genes, but they're not, their ferritin is normal or low. I tell them what the doctors tell me, hematology doctors, that the red meat could hurt, it's going to fuel it, and so on and so forth. But you brought up a great point. If you're willing to phlebotomize, if you're willing to put it all together with all these vector forces, you have to look at each man independently. So I like that. I usually say plant-based diets and so on and so forth, but we know that if you're willing to phlebotomize and look at the ferritin is key for you. Ferritin is that is your holy grail, ferritin. And that's because you have hereditary hemochromatosis. Other men are going to have low ferritins. You see, this is it. And then they phlebotomize a little too much or at all, and not at all sometimes, just because they're taking out of the ferritin when they don't have the storage gene, and they have low ferritin, and then the doctor is giving them iron tablets. Sir, I can't tell you how complex this is on both ends of the spectrum that we just don't know. So hopefully this video is going to shed light on men's education for androgen therapy. You have to be diagnosed properly. You have to look at the labs, not just do these routine knee-jerk labs and kind of make sense of them. You have to really understand the pathophysiology. And I hope this really drives home. I don't know everything. I certainly have learned a lot about hereditary hemochromatosis, but what doctors have to do 50 things, not to mention any person in their day job, you become a specialist just in one thing. But you have to have broad education, and you have to be careful with anything we do. So I'm going to thank you so much for this. This is absolutely outstanding. Guys, anabolic.app.com, you could see all this information. Access to me on a limited sense, for medical information. I'm never your doctor. This is just medical information always. But you have to understand the future. You're going to take charge of your health, and then you're going to use your providers. Like this man right here, and it's going to be piecemeal, guys. You have to do it systemically. A, B, C, D. You have to do it yourself, guys. So thank you, sir. Thank you so much. This is super cool. We'll come back once your ferritin's down, a year later. We'll come back and we'll revisit this in a future. Thank you, sir.
Thank you, Doc.